Now we can start. Yes. Shivani, we can start.
Okay.
Good evening, everybody. We are live on YouTube. So, good evening, respected faculties and delegates present over here. On the behalf of Corona Remedies Limited, I welcome you all in the AMOGS webinar. So,
Yes, Shama.
Yes, welcome.
Yeah.
Welcome to today's webinar. It is AMOGS Sexual Medicine Committee associated with Andhra Pradesh OBS Kind Societies, Guntur, Vijayawada, Visakhapatnam, Srikakulam, Rajahmundry, Elur and Bhimavaram. So let's start our today's session. I would like to introduce our conveners of today, Dr. Madan Kamble sir. He is the chairperson AMOGS Sexual Committee 2024 to 26 and the national coordinator of Sexual Health and STI Committee from 2024 to 27. He is a past president, Akluj Obskyne Society, Maharashtra. And we have another convener with us, Dr. Prerna Kishan. She is East Zone Coordinator, Young Talent Promotion Committee. She holds many prestigious positions and participated in many conferences. Well, we welcome you, sir and ma'am. Please take on the session.
so
Yes.
I
Yes,
would
thank you,
like to
Shama. Yeah, Shivani. Yeah, we will continue. Yes,
Yes.
thank you so much.
So I would like to welcome Dr. Shama. Dr. Shama have done MBBS and DGO. She is a South Zone Coordinator of Sexual Health. She is a scientific committee member and also a member of ISAR, contributed in AICOG manual. So I welcome Dr. Shama in a next webinar.
Thank you. Thank you. Yeah, thank
Yes.
you. I request Dr. Madan sir to introduce our chief guest.
Yes. Good evening, everyone. It's my proud pleasure to have association with Andhra Pradesh societies on behalf of AMOGS. AMOGS is continuing this series since 2 years, and we are so happy to connect with each and every state. This is the second episode with Andhra Pradesh societies. And thank you all the societies of Andhra Pradesh for having this consent with pleasure with AMOGS, and we are so happy. And we are having 7 societies today, as Dr. Sharma has stated. And for this particular webinar, we have got eminent chief guest, President-elect Foxy, Dr. Madhuri Patel ma'am, our guest of honor, esteemed persons, our dear own Dr. Kiran Kurtkoti sir, President AMOGS, Dr. Venkat Rao sir, President of Guntur Society, and Dr. Padma Sajja ma'am, President of Rajahmundry. And also, I welcome my co-conveners, Coordinator Dr. Sharma, all the chairpersons for this session, speakers, Dr. Lalita, and all the chairpersons for this today's webinar. AMOGS is always trying to create the awareness and spread the awareness about the sexual health throughout the AMOGS and also all the societies of FOXY. And our aim is to create awareness about amongst the our gynecologists first. Then we can serve the society. Thank you so much. And I would like to welcome and introduce Dr. Madhuri Patel ma'am. Can I have the CV of ma'am? Yes, ma'am doesn't need any introduction. She's a sweet lady of Foxy. Everyone love ma'am, and ma'am loves every Foxyian. She is the president-elect Foxy and past secretary general of Foxy. Everyone knows ma'am, and we are very eager to hear you, ma'am. Over to you, ma'am.
Thank you, Madan, for your kind and warm introduction. Respected President AMOG, Dr. Kiran, he is my great friend and we have worked together. We grew up together, I will say. And nice to see Kiran over here as a president and guest of honor. Then we have Dr. Bipin Pandit. He is also from Mumbai, very good friend of mine, secretary of AMOGS. And today's guest of honor, Dr. Venkateshwara and Dr. Padma Saija. But then I would like to say that, I have traveled all this society during my secretary post as well as during my election campaign. They all are very, very loving people and they really take care of you. Of course, we have then Convener Dr. Madan, who is doing excellent work not only in AMOGS but also in the Foxy committee. And Dr. Prerna, again a young girl, Debrugarh, I remember how much care she has taken. Then Dr. Shama, Dr. Uma Shankar, Dr. Revati, Dr. Tripura Sundari, Dr. Padmavati, Dr. Somlata, Dr. P. Jayanti, Dr. Lalita, Dr. Nirmala Devi, Dr. Arvinda, and all my dear friends. Very, very good evening to all of you. At the outset, I would like to thank AMOG's Sexual Health Committee, Dr. Madan and Kiran, for giving this opportunity. As we know, the female sexual dysfunction involves persistent problems with desire, arousal, orgasm, or pain causing distress, often stemming from hormonal shift, that is especially during childbirth and menopause. And patient are diabetes and cancer. Those drugs also can give a problem. And most important nowadays, many of the women are undergoing depression, they are on anti-depression drugs, and that can also create a problem. And most important is, partnership issues. So these are all psychological problem and medical problem can give rise to female sexual dysfunction. So I'm really happy that Madan is going to talk about sexual history taking, which is very, very important, physical examination, your laboratory test, spatial test, and you can put counseling, hormonal treatment, and anti-depression treatment, and any other treatment which are suitable for this function. I remember when I was Secretary General, Neeraj Jadhav was the chairperson of Sexual Health Committee. And he told me only one question. He asked me only one question. Madam, who will provide the platform for my committee? Because nobody is interested, no pharma is interested in this committee. I said, I will provide, Foxy will provide you. And he did a multiple, webinars on this. And now today there are many companies, they've realized they're coming forward to support this sexual health committee. So awareness and sensitization of not only of gynecologists is important, but also of our community is important. With this, I will not waste your more time, and I wish all the success for this webinar, and I wish best luck for your future endeavor. Thank you once again for giving me this opportunity.
Thank you so much, ma'am, for taking a precious time from your busy schedule and blessing us. Thank you so much. Over to you, Prerna.
Thank you. Wishing you all a very good evening. And we are immensely honored to have you all amongst us this beautiful evening to host you for this wonderful, pertinent topic of sexual health and reproductive medicine. We now welcome, I thank Dr. Madhuri Patel, ma'am, for her insightful and her blessings. And ma'am is always very loving and inclusive. And ma'am, you are a gem of a person, I must say this. And we always look forward towards your tenure. Thank you, ma'am. We now welcome our guest of honor for today, very beloved Dr. Kiran Koti, sir. Sir has adopted me to AMOGS, he said, in the last SUG. Sir is the president of AMOGS, and sir, we are all here to take your words of wisdom.
Thank you. Thank you. Thank you so much. At the outset, my warm regards to our chief guest, Dr. Madhuri Patel, and of course to my co-guests of honor, Dr. Venkateshwara Rao and Dr. Padma Sajja. And of course, Prerna, yes, we have adopted you to AMOGS, and we have, just like you, we have adopted many people who are non-AMOGsians into AMOGS, because AMOGS always believes that in inclusivity. Madan, you are doing a fantastic job, and Prerna Madan, I am sure that you will succeed in your endeavors in Foxy. And of course, please keep on grooming youngsters like Dr. Shamas. So please go ahead with that. And with this, I take an opportunity to invite you to two main functions. Number one is the AMOGS that we are going to have on 13th, 14th, and 15th of March, where I'll be handing over the reins to Dr. Ameya Purandare from Mumbai. So please be there in large numbers for the AMOGS 2026 at Mumbai. And secondly, we witnessed a very grand installation of Dr. Bhaskar Pal as the president of AMOGS. And I'm sure that all of us will love to go to Surat when I see my friend Dr. Madhuri Patel being installed as the president of our great national body, that is FOXY. So please mark your dates. I'm telling you 1 year in advance, 9th January onwards. So the diamond
6 to 10 January.
6th to 10th of January onwards, the diamond capital of India, Surat. Please mark in your diaries. There are a lot of flights to Surat. So please let us all be in large numbers and see the Iron Lady of Foxy. I can call her as the Iron Lady, the gentle Iron Lady. I don't know what you can say, but the gentle Iron Lady of Foxy, Dr. Madhuri and my friend, being installed as the president. So with this, I think a warm welcome on behalf of AMOGS also to all the Andhra Pradesh societies, because AP societies have always been together. We have always conducted lots of workshops, and Madan, you have been instrumental in gathering all the AP societies. And my warm welcome to all of you to this fantastic webinar. And Madan and Dr. Madhuri has already highlighted the importance of the Sexual Medicine Committee. As a matter of fact, we have got, AMOGS has got two separate committees. One is for the sexual health and the other is for cosmetic gynecology. We have had good courses in cosmetic gynecology also. And Madan and Prerna and Shamaji, in case you feel appropriate, you can start a course on sexual medicine also on behalf of AMOGS, so that more and more people get to know the nuances. So with this small bit of my talk, I hand over these again to Madan, Prerna, and Shamaji. And of course, please get on with the webinar. And my warm personal regards also to Professor Venkateshwara Rao and Dr. Padma Sajjan, Madam, also, who are the presidents of Guntur and Rajamundry. Thank you.
Thank you,
Uh,
sir.
Thank you, sir. Thank you.
Kiran, thank you very much. Of course, I would like to say welcome all of you in Mumbai for AMOGS, conference that we already mentioned on 13, 14, 15 March. And of course, January 6 to 10 for the Surat AICOG 69. And, I would like to welcome all of you and, we'll have a great time at both the places. So thank you once again.
Thank you, ma'am. Thank you, Kiran sir, for always
Thank you,
being so
Kiran sir.
inspirational, always being so inspirational and motivational. Sir, it's always good to hear from you. Your blessings are indeed our treasure. Thank you so much, sir. We now welcome our next guest of honor, Dr. B. Venkateswar Rao, sir. Sir is the president of Guntur Society, and sir is the professor and HOD of Katuri Medical College and Hospital, Guntur. Sir, we are so very honored to have you amongst us. The dais is all yours, sir, for your words of wisdom.
Yeah, thank you very much. Thank you very much, Madam Madhuri Patel and Dr. Kiran sir and Dr. Madan and everybody, all the things. And the sexual medicine is a very important part of the gynecological societies where the awareness of the woman should be there. And we thank you very much, Madam, for giving the importance to this. And wish you all the best in the Surat, Madam. We will definitely attend the Surat conference. And Shama Sultana is doing a lot of work in Guntur, Madam. I am very happy to tell that. And thank you all and wish you all the best in the coming ceremony. Okay, thank you very much.
Thank you so much, sir. Thank you for being with us today. This next. Shivani, can you make it large?
Yes, sir, it is large.
Okay. Now I welcome our guest of honor, Dr. Padma Sajja, ma'am. She is a great academician and currently the president of Rajamundry Society. Ma'am is director at Pragati IVF and Laparoscopy Center at Rajamundry. And she has faculty at many conferences, organized many conferences in AP. She was also organizing chairperson for upcoming South Zone Yuva Foxy 2026, which is going to happen in Rajamundry. Yeah. Welcome, ma'am. We
Thank
are
you so much,
very
sir,
happy to have you. Over to you, ma'am.
Thank you so much, sir, for your nice introduction. And good evening, everyone. And I feel really honored and privileged to be a part of this wonderful seminar. And at the outset, I would like to congratulate all the organizers, especially Madan sir, Dr. Prerna, and Shama Sultana for organizing such an important and this sensitive subject. Yeah, which is often under talked and often talked in hushed tones, rather less exposed, and but still it's an important area. And my best regards to our President-elect Madhuri Patel, ma'am, will be definitely there for your swearing in ceremony, ma'am. And my best regards to other guest of honors, Dr. Kiran Karkoti and Dr. Venkateswar sir, and other warm wishes to other chairpersons and speakers and audience as well. And we all know sexual medicine is very, very important, but somehow we got less exposure during our undergraduate and postgraduate days as well. And in our day-to-day practice, we definitely face many questions regarding in this area. But most of the times we ignore them, saying this is of psychological origin because this is lack of proper information on this subject. And webinars like this definitely improve the knowledge of many of the gynecologists and which might help us in our the regular practices. And I'm really looking forward to listen to all the topics. Thank you very much for again for making me a part of this webinar, and thank you very much all the organizers and the audience also. Thank you so much.
Thank you so much, ma'am, for your kind blessings, and we wish you all the best for your upcoming conference. And
Yeah,
we would like to attend this conference, and kind request to keep some session
definitely,
on
sir.
sexual health,
Can
if
I take
possible.
one minute? I would
Yeah, yeah,
like to
please.
invite you all of you for our upcoming UA Foxy that is being conducted in the month of September 4th, 5th, 6th. In in 2026. And Rajahmundry, you all know it is very vibrant and spiritual city surrounded by a lot of temples and greenery and mighty river Godavari and Papi Hills. And definitely you're going to have wonderful time at Rajahmundry. Please do come and grace our conference at Rajahmundry. I invite wholeheartedly everyone.
Yes,
Thank you.
thank you so much, ma'am.
Thank you.
So I would like to invite all the dignitaries for the e-lamp lighting. Shivani, yeah, please play.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय ॐ शान्ति शान्ति शान्तिः
Yes, thank you so much once again, all the esteemed dignitaries and all the guests and guest of honors for blessing us for this particular webinar. By taking this opportunity, on behalf of me and Dr. Prerna, would like to seek your blessings for our upcoming Foxy Chairperson elections, which are going to happen in August 26. I'm going for Sexual Health Committee of Foxy. Dr. Prerna is going for YTP Committee of Foxy. I request all the presidents and secretaries and all the seniors of Foxy to bless us. Thank you so much. Over to Shama for the scientific.
Wishing both of you all the best. Okay.
Yeah, thank you, ma'am. Thank you.
Okay, Shama ma'am, you can share. I am stop sharing. Okay.
So let's start our scientific program, session 1 on sexual history taking. The speaker, Dr. Madan Kamble sir. And to chair this session, we have Dr. P. Revati ma'am, Dr. Tripura Sundari ma'am, and Kanakala Umashankar sir. So Dr. Pandula Revati ma'am, she is a professor in HOD, GEMS Medical College, and President Srikakulam Obsgyne Society. She published more than 30 papers in various journals, speaker in various conferences. Area of interest is high-risk pregnancy and gyne endoscopy. Dr. Tripura Sundari ma'am, she is a retired HOD, Government Medical College, Vijayawada, presently professor at Ashram Medical College, President, Vijayawada Obsgyne Society. Dr. Shanakaila Umashankar sir, he is a clinical head, Ahalya Hospital, and Secretary GOX, Joint Secretary APOGS, and Executive Member of APSISR, Organizing Secretary of 5th AP COG, and Organizing Secretary of South ISR 2025. He has won many prestigious awards. One of them, or recent times, is Dronacharya ISR Award 2024. We welcome all of you, sir. Please take over the session. I request one of the chairperson to introduce Dr. Madan Kamble, sir. Dr. Umashankar, sir. Dr. Revati ma'am, you can introduce Dr. Madan Kamble, sir. Or Tripura Sundari ma'am.
Yeah. Thank you so much. I'm not able to see the slide.
Yeah, it's okay, ma'am.
Yeah,
I have already been introduced.
Ma'am, is it visible?
One
He's a
second.
chairperson AMOGS Section Committee, ma'am, and national coordinator of means Sexual Health and STI Committee.
No,
Yes,
it's
sir.
okay.
Please take over.
Yeah, thank you so much. Shivani?
Yes, sir.
Yeah. Allow me to share.
Okay, sir.
ಇವತ್ತು ನಮ್ದಿರೋದು 8 ಗಂಟೆಗಲ್ವಾ ಅದು?
Is it visible?
Yes.
Yeah. So we welcome Dr. T.S.S. Rao, sir, great stalwart in the field of psychosexual medicine in India.
Thank you so much.
Yeah, welcome,
All
sir.
the best.
Do a slideshow, sir.
Yeah.
Yeah, it's done.
Is it okay, no?
Yes.
Yes. Good evening, dear friends. I have purposefully selected this topic, how to take sexual history, because this is the basic part in the field of sexual medicine. Everyone should know the basics. We don't expect that everyone should practice sexual medicine, but as a obstetrician and gynecologist, we should know the basics of sexual history taking. We know sexual health is greatly affecting the overall quality of life. And that is why it should be a routine part of our history taking, as well as when there are some clinical features suggestive of sexually transmitted infections. Then what is the purpose or what is the benefit of this sexual history taking? So it gives you high quality patient care by appropriately assessing and screening the individuals to a broad range of sexual health concerns. And always this history taking should be comprehensive, and it helps you to reach our diagnosis. Then first thing comes how to start with, or how to create this clinical environment. Then to create a clinical unwelcoming environment for the patient should begin at the registration. And first we have to establish the patient's name and pronouns, as well as their sexual orientation and gender identity. This is very important. And as usual, we have to gain the consent before starting the history taking or examination. Gender identity is independent of sexual orientation, and it should be determined by two steps, that is the sex assigned at birth and current gender identity. Sex assigned at birth may be female, male, or he or she may decline to answer. And current gender identity may be female, male, transgender male, gender diverse, etc., or may decline to answer. Some patients may not be comfortable talking about their sexual history or sexual partners and anything about the sexual practices. But don't forget to ask about any past experience of abuse or trauma. The patient should also know that to take a sexual history is very important. That is a regular part of the medical care. And as with the other history taking, we must consider how to put the patient at ease and find out what is the real problem and discover the patient's background and clinical history. And then we can work out a plan for the management of that particular patient. One should know the general communication skills, how to go ahead in these cases. Important first is the professional attitude. Our attitude should be professional. There's self-introduction. We should introduce the patient. For example, welcome, please have a seat. I'm Dr. Madan. I'm going to take care of your the problem for which you have come. And second thing, always be cool and polite. Never try to be judgmental. Be always non-judgmental. Your body language should be confident. There should be eye to eye contact with the patient, and you should be confident about everything, asking the questions and regarding the counseling. Again, important thing is history of both partners is very much necessary. And last but very important is to ensure the privacy and confidentiality to the patient. We should first assure them that our discussion is totally private and it will be 100% confidential. So don't worry. Then they will open up. Then these are the basic history notes we all are knowing since undergraduate days. Name, age, sex, address, religion, marital status, occupation, education, contact details, information about the family members. Then the main history starts, that is past history, personal history, family history, medical history, surgical history, obstetric history, and last is the sexual history. Every part of this history is important. In the obstetric history, we have to ask details about the her obstetric career, about the deliveries, whether normal deliveries, cesarean, history of episiotomy, surgical history, LSCS, any medical history, if she is on any drugs, any antihypertensives, anti-diabetics, anti-thyroid. And then today we are focusing more on the sexual history. Then how to start the discussion? There are many questions which are ready in our mind and that we have to go slowly, making the client more comfortable. Initially, to start with, we can ask, may I ask you a few questions about your sexual health and sexual practices? I understand these questions are personal, but these are very important for your overall health. And at this point in the visit, I will ask some questions regarding your sexual life. Will that be okay for you? This type of question. Then that will make the patient relax and more comfortable. And one thing, remember, all these questions regarding the age, gender, and marital status should be asked to each and every patient because these questions are very important. This information is kept in strict confidence unless you or someone else is being hurt or is in danger. So confidentiality part is very much important. And we can ask the patient like this, do you have any questions before we get started? Do you have any questions or concerns about your sexual health? That means these are the open questions or leading questions that we can make them start. In many centers, there are some questionnaires or inventories for male and female. In India, also many centers use this or customize this. Some questions and people, when the patient comes in our OPD, we can hand over them some questionnaires and they can tick the particular questions and answers. And according to that, that will help us to reach the diagnosis easily. Then some open questions and closed questions. Then open questions like, how can I help you? What is your problem? What do you think that this difficulty has caused due to? And closed questions, these are answers are expected in yes or no. Have you had this problem before? Did you practice safe sex? These are the general questions, but we can dig out the answers. Then about the finding out the problem. Avoid use of words like importance. Never use the word importance. And always handle carefully and tactfully. Vagueness must be clarified. Then about the use of terminology, in which language we should talk with them, which terms should be used, whether to bring vernacular terms or the medical terms. But many times the use of street versions or these street versions may assume or may make the patient very relaxed and comfortable for the discussion. These are the six main domains on which discussion goes on, or main concerns about the problems of male and female, like desire, arousal, penetration, ejaculation, orgasm, and pain. Or questions will go on main these domains. Then ask detail about every question, like onset, duration, severity, progress, and regarding the problem, and are there any aggravating factors, any relieving factors, and any associated factors that we have to ask. Then how to have the clinical evaluation of such cases. First, ensure that the sexual identity of the patient, sexual orientation. Then ask about the sexual activities and sexual function, whether it is normal, how they do the sexual act, or about the sexual practices, whether it is normal or is there any problem. Ask about their general health status. Ask about the comorbidities if they are having. Ask about the interpersonal relationship factors. There may be some cultural barriers, some religious beliefs that might have caused these dysfunctions. Some personal expectations also cause the dysfunction, because there may be mismatch in the expectation of male and female partners about the sexual practices. Then there are 5 P's for the sexual behavior history taking. These are very important, and these will help us for the to reach the proper diagnosis. The partner's practices, protection from STI, past history of STI, and pregnancy prevention. These are the 5 P's. Then what is the goal of these 5 P's? The goal of the 5 P's is to improve the patient health and to solicit the full disclosure of the sexual practices of the patient. Then we will go in short one by one. And about the partner, we can ask few questions regarding the partner. Are you currently having sex of any kind, oral, vaginal, anal, with anyone? If no, have you had ever had sex of any kind with another person? In recent months, how many partners you have had? What were the genders of the sex partners? Do you or your partner currently have another sex partners? These questions should be asked in details. Then about the sexual practices, we need to ask some specific questions about the types of sex they are having in last 12 months. We have different tests that are used for the different body parts people used to have sex. Would that be okay? That means you have to ask about the practices, then go in details of the sexual practices, like what kind of sex they are having, like genital sex, anal sex, oral sex. And you can ask, are you top or bottom? Do you meet your partners online or through apps? Have you or any of your partners using drugs? Have you exchanged sex for your needs? These questions are difficult, but have to ask whenever we encounter such cases. Then about the protection from STI, we have to know their knowledge of regarding STI. Do you and your partner discuss the STI prevention? We have to ask some questions to test their knowledge about the STI prevention. If you use prevention tools, what methods do you use? Condoms or anything else? How often do you use these methods? How frequently? When you are using, when you are not using? Have you received HPV, hepatitis A, or hepatitis B shots? Are you aware of post-exposure prophylaxis? And have you ever used it or considered using it? These questions also should be asked. Then past history of STI. Have you ever been tested for STI and HIV? Or would you like to be tested? Have you been diagnosed with STI in the past? When? Did you get treatment for that? Have you had any symptoms that keep coming back? Has your current partner or any former partners have been diagnosed or treated for an STI? Where you tested for STI? Do you know your partner's HIV status? There are so many questions to know about the sexually transmitted infections history. Then what are the prevention strategies for STI? First important is not having sex, but that is practically impossible. But most important thing is they can have mutual monogamy, or both the partners having sex with only one another, using a post-exposure prophylaxis and using condoms at every time. That can prevent the sexually transmitted infections. Then last P is the pregnancy prevention. We have to assess their knowledge about the prevention of pregnancy, importance of prevention of pregnancy, their willingness. Do you think you would like to have children at some point? When do you think that might be? How important is it to you to prevent the pregnancy? Are you or your partner using contraception or practicing any form of birth control? Would you like to talk about the ways to prevent pregnancy? Do you need any information on birth control? So many questions are there, and for the pregnancy prevention information. Then how to give the final touch up or closing the consultation. Other questions like what other concerns or questions regarding your sexual health or sexual practices would you like to discuss? And always ask history of any trauma, any sexual abuse or violence in the past, because this is a very important issue and one should not miss to ask. Also consider asking about the sexual functioning, including pleasure and performance. But it means they are enjoying sex or not, performance is well or not, or is there any problem? Many times there is performance anxiety and they cannot perform. And always summarize once the all the discussion that has been done with the patient or couple. And finally, again, you can reaffirm the confidentiality of our discussion. At this point, we can thank to the patient for being open and honest, always encourage their openness and honesty, and you can point out and encourage any protective practices also. The last part is agreeing a management plan. This is the final part of history taking, and management plan is to be discussed and agreed with the patient or the couple. And this thing is important, involvement of patient partner for a joint meeting. During the history taking, first we can take the individual history, then couple history, and at the final plan, we must involve the patient partner for the success of our treatment. And what does this? This does the patient will feel that there is a good partnership between me and doctor, and that is very much needed for the success of the treatment. Thank you so much for the patient listening. That's all. Yes. Any chairpersons, if any questions, you can go ahead.
Sir, very good presentation, sir. So can I ask you one question, sir? How
Yes,
for the, is there any difference in the opening up of between a male and a female regarding the history? Any difficulties you face between these two?
No. That is why at the initial discussion, I stated that we should first make them comfortable. Make them
Your
comfortable.
experience.
And if they are hesitating, we can have the couple in front of
Yeah.
and or else we can take first history of one partner, then another partner, and finally them both. And generally, both will open very well after making them comfortable.
Do you
But we
allow
have to
the
take,
parents?
yes.
Sometimes the parents also want to come in the discussion.
No, better to avoid in the first meeting.
Okay.
If the patient, both husband and wife are comfortable involving them, then there is no issue. We can involve them in the final meeting.
Okay.
But initially, during the history taking, we should first talk with the clients, both the partners, male and female.
Okay.
Many times, what happens before the parents, they may not open up.
Okay.
Thank you.
Thank you, sir.
Thank you. Thank you, Dr.
Thank you.
Madan. And on to our next session, and that will be taken by myself. I am the National Coordinator of Young Talent Promotion Committee of FOXY, and I welcome all our chairpersons for this session. Can we have the CVs, please, on deck?
Yes, ma'am.
Our first chairperson is Dr. Padmavati Ji. She is from Bhimavaram. And Dr. Padmavati Ji, ma'am is the president of Bhimavaram OBGYN Society. We are so very honored to have you, ma'am, amongst us. Our next chairperson is Dr. Somlata. Dr. Somlata, ma'am, is from Vijayawada. And ma'am has had a lot of credentials to her credit, and she has been affiliated to a lot of organizations, and she is a consultant gynecologist at Bhargav Nursing Home, Vijayawada. We welcome you, ma'am.
Yeah,
And
thank you.
third chairperson is Dr. P. Jayanti. Ma'am had been bestowed as the best outgoing student during her MBBS days, and she has multiple trainings in various facilities. Ma'am, we welcome you, and we move on to our session. If in case you have any opening inputs, you can please give for this session. I am talking a bit apart from what has been given to us, the sexual health and reproductive medicine. We are talking more about preconceptional counseling. And we take this opportunity for every patient who is coming to our clinic to, can I share my screen?
Yes, ma'am.
Yes.
Yeah. So every patient who comes to our clinic, we take this opportunity as a preconceptional care. I bring greetings from Assam and also from the Young Talent Promotion Committee. And we are in a state where we need to understand that having a preconceptional counseling and care is preventing a perinatal crisis, because this is a comprehensive approach to ensuring the best possible start for every pregnancy through strategic health intervention and informed planning. Now, why preconceptional counseling matters is that 40% of unplanned pregnancy, nearly 4 in 10 globally, significant risk of health to both the mother and the child occurs in such cases. 50% of higher perinatal risk when a preconception counseling is not done, as well as there are 20% of preventable death that can happen when the maternal undernutrition and iron deficiency anemia is corrected in the preconceptional period. So these stark statistics, they highlight the critical need for proactive preconception care to protect maternal and infant health globally. Now, why this matters is because of rampant growth of metabolic syndrome in Indians, with its combination of central obesity, type 2 diabetes, hypertension, and dyslipidemia. This all makes a woman contemplating pregnancy more vulnerable to perinatal complications. Now, if we understand that when are we going to meet the healthcare professional, it has to be way before attempting to become pregnant. And this particular thing is very, very biased. People do not come to us. By the time we get a pregnant female, she is already 5th week pregnant. It includes a preconceptional risk assessment as well as a modification of existing risk factors. Now, the set of interventions that aim to identify and modify biomedical, behavioral, social risk to women's health and pregnancy outcome throughout prevention and management. Now, the aims of preconception care are we need to optimize her health status, we need to reduce her risk factors, and we need to detect in an early phase whatever is effectively managed with an emerging health risk before the pregnancy begins. Now, the established facts and myths is that apart from the diagnosis and treatment, we are supposed to provide primary preventive care. So PCC is all about primary preventive care. The benefits of deliberately preparing for pregnancy relate to the important and critical period of organogenesis. Let me repeat this. It relates to the important and critical period of organogenesis, which occurs between day 17 and day 56 post-fertilization. Now, by the time we get this patient, they are already 5th week pregnant. So the period of organogenesis already started. So the folliates has to work in this particular time when between day 17 to day 56. So we are not getting these patients in this particular window. So the traditional early prenatal visit is too late. It is too late to affect reproductive outcomes associated with abnormal organogenesis. So if a patient who is coming at 5th week pregnant, her LMP is 17th of December, she came to you at 17th of January has crossed, she checked her UPT and 20th of January, and that is a 5th week pregnancy, we are not able to do much about the organogenesis defects if there is or going to happen, any of that. So the couple seek help preceding pregnancy is a duty to consider each visit of a woman of reproductive age. Now, they can come for a sexual health disorder, they may come for arousal disorder, they may come for a dyspareunia, they can come for a vaginismus, but any of these women who are coming to a clinic, we need to take this opportunity with them to counsel them and encourage them about preventive care. Now, the newlywed couples, this can be anybody. They're newlywed couples who are seeking in for contraception. The women who have thought that she is pregnant, but the negative pregnancy test was there. The woman who have just had a spontaneous abortion 3 months back, and somebody who is undergoing infertility or maybe a treatment for sexually transmitted infections. These are the area where we can take the opportunity to do a PCC, a preconception counseling or care. The components include nutritional support. The very, very ironical thing about this is that no curriculum till date had spoken about this. Since we were postgraduates, no curriculum had spoken about preconceptional care and counseling in complete detail. So this time also in AICG, we had launched a book on post-graduation textbook of OBGYN, where we have included this chapter as one of the major chapters for the postgraduate students. Now, this includes nutritional support, genetic assessment, disease management, immunization, as well as lifestyle counseling. The majority of the pregnancy is still unplanned because globally 38 pregnancy, as I've already mentioned, there's lack of awareness we need to break. Not only with the doctor community, we need to go to the outreach programs, we need to conduct outreach programs and tell them the significance of PCC for the common masses, how important it is. Now, the benefits of PCC it's huge, it's humongous. It can save lives, it has healthier birth benefits, it prevents transmission of so many infections if detected at timely basis, and ideally that the time is 3 to 6 months before actual attempts are made to conceive, and this time frame allows a woman to better prepare her body for successful conception and allows her to reduce the modifiable risk factors. Like Hindi mein bolte hain, it's like something like this, ek zameen ko ready करते हैं तभी बीज अच्छा वृक्ष देती है. So it's like that. If we sow a good seed into a good land, it's prepared land, then only we'll get good plantation. So this is what is a motive of preconception counseling. You have to prepare this woman way before she wants to become pregnant. Now, the identification of the pre-existing risk factors, potential risk factors, screening of common medical disorders which have an impact in pregnancy, like GDM, like hypertension, like hypothyroidism, genetic counseling, wherever it is required, in nutritional counseling definitely is required in today's date with so much of junk food around us. Now, the goals we all know, it is to improve the knowledge and attitudes and behavior of the woman. We ensure that the childbearing age group women have this proper services for optimal health, as well as we reduce the risk indicated by the previous adverse pregnancy outcome, if there is any. If she had any miscarriages, she had any ectopics, if she had any spontaneous abortions, we need to take care in this preconceptional period. We need to reduce the disparities of adverse pregnancy outcome. This is by the CDC, and it has been referred as the Select Panel on Preconception Care. The key components we have already discussed. It is reproductive life plan. There where this topic comes into this particular webinar of sexual health is the reproductive life plan, the past sexual and reproductive history, the medical assessment, medication use, infections and immunization. As we all know that that she has to go through genetic risk assessment, healthy weight and nutrition. A woman of having a BMI 39 and wants to just jump on to become pregnant, she'll definitely end up into having PET and GDM. So we need to understand that these psychological and behavioral risk patterns with a healthy environment and physical assessment is quite necessary that before she can become pregnant. Now, what is basic in-depth information is that lifestyle, diet, exercise, stress relief, detailed family history, personal history of drugs, smoking, alcohol abuse, very, very common nowadays. We get patients in our OPD saying that, oh, doctor, I had booze last night, but now I know that I am pregnant. I checked this morning, I'm pregnant. So they are just popping on a pill, and then they are just going around with clubbing and then having alcohol and boozing, and then they become pregnant. So this is really unhealthy of their lifestyle. So we need to understand that the pre-existing morbidities and screening for diabetes, hypothyroidism, hypertension, as we all said, folic acid supplements, we all know, but we are not calling these patients 3 months prior to pregnancy, and maternal undernutrition and IDA is the hallmark of Indian scenario. Now, why is it so significant? Because preterm births, every obstetrician and gynecologist is terrified with this word preterm birth. Once preterm labor onsets, there is nothing that can prevent it. So we can have a lot of prevention of preterm birth if we meet these patients in the previous 3 months prior to conception. even fetal growth restrictions. Once it's onsets, it is a irreversible procedure. So we have to understand that FGR can also be diminished with meeting this clients way before pregnancy. Congenital anomalies, definitely they do have a reduced outcome of congenital anomalies, as well as parental morbidity and mortality is definitely reduced. Now, the age they have in this particular scenario of today's AI age, we have so many patients getting pregnant and at the early teenage, or maybe getting late in the 30s, maybe 35, 37, 38. So they likely result in lower birth weight infants along with prematurity. So women who are more than 35 years of age, they are prone to chromosomal anomalies. We all know they are prone to miscarriages, they are prone to fetal aneuploidies, they are prone to coexisting medical conditions. So we understand and take this risk factor assessment and counsel them way before pregnancy is there. Now, the medical history we need to take in total detail about asthma, thrombophilias, hemoglobinopathies, autoimmune conditions like SLE, diabetes. We have all said epilepsy is very, very important thing. They feel that they have, one of my patients, she had this silent seizures, absent seizures. So they do not manifest much. While sleeping, she has little jerks, and then she was on this Aptoin. And she never thought the importance of mentioning it. We put her to the OT table, and when the anesthetist asked her about, well, he was digging into some question because her look was quite blank. So the moment she said, I have been on Epiton, I never thought that it is very important. So even when my doctor asked, I never mentioned it. So we have to dig into these patients, that whether they are taking any extra medications, OTC medications, apart from that, whether the routine medication they are taking. Apart from this, that malignancy screening, renal diseases, we can also go for a pap smear test in this. And this is not moving. So this is it. We have family history as well. That is congenital anomalies of family history, mental retardation, as well as detailed menstrual history is very important. Ectopics, RPL, all these come into play. Whether in the previous pregnancy she had any eclampsia, whether she had any placental abruption, whether she has any history of cervical or uterine anomaly, or whether the baby whom she had delivered earlier, whether that baby went to the NICU or not. So this is also a very significant history. Drug history, I've already mentioned how to go about it, and the HbA1c levels should be less than 6. Immunization, we all know the Hep B status has to be there, the rubella status has to be confirmed, and vaccination has to be proper. If in case she is taking rubella at your clinic, you have to ask her for a full month of precaution. And this socioeconomic status, a very, very important thing in PCC, because socioeconomic status evaluation has a lot to do with the pregnancy outcomes, because nutritional status, hemoglobin levels, they all depend on the socioeconomic status of the females. And this IDA has to be given to all females who are in the low strata of the population. And potential teratogenic exposures are common in slum areas than in the areas where posh areas where people settle down. So passive smoking is a very, very important thing. We need to understand, and we need to ask the client who is coming to us whether your husband smokes, and whether how many hours are you there whenever he smokes in the room. And the pre-pregnancy weight, I have already mentioned. Healthy weight reduces the risk of NTD, PTL, GDM, cesarean delivery, all such things. And vitamin D is also one of the most upcoming thing that we all need to see. Invasions and the role of nutritionist then comes into play. The behavioral details. This is a very, very important thing for this particular webinar, where we need to understand the high-risk sexual behavior of these patients. If they are having multiple sexual partners, definitely they can end up into having a baby with a VDRL positive, with a treponema pallidum positive. And then if she has a sudden IOD at 9 months, then they are going to catch your throat. So this in the era of medico-legal litigation, we need to very well understand, once a patient either become pregnant or she comes to you prior to pregnancy, you have to ask how many sexual partners did you have before you were at all married, or even after marriage, do you have any multiple sexual partners? A very important, maybe absurd, but needs to be, you have to do it for your own safety and for the better outcome of the pregnancy. And improvement of emotional well-being definitely is a very, very important factor. Exercise in pregnancy of paramount importance. We all know regime of stretching, walking, and mild aerobics should be routinely followed. And the short interval pregnancy. If she is having a baby who is already only just 1.5 years old, then you have to understand that you have to either tell her that it is there are chances of counseling has to be done on the fact that avoid short interval pregnancy has to be avoided, but once she is pregnant, you have to carry on this pregnancy with a lot of caution. The preventing NTD, we have already said, you all know, with the previous history of NTD, 4 mg of folic acid is required, and without a history of folic acid, NTD, 0.4 mg is there. Lab investigation, we all do, we all know all these particular factors. Apart from this, we can go for a 2-hour GCT with suspected cases of OGTT and GDM or intolerance. So the usual questions that are asked to us is that, is the counseling best targeted to certain general population, or it's a specific subsets that need counseling only? No, it is universal. Every client who is coming to you in the OPD can have a PCC if she is planning a pregnancy. Offered as a routine component or delegated to special visits? No, it is offered as a routine component. Do all potentially fertile women need PCC? Yes, they do. Is it cost effective? It's very much. It just needs a just needs maybe a 10 to 15 minutes time from your end. How can a busy practitioner incorporate prevention emphasis into routine encounters is the question most importantly asked. So what we can do is that to overcome the challenge, we can break this socio-economic barriers, we can make awareness gaps, then we can professional training to our subordinates, as well as we need to be very, very culturally sensitive, because one particular question can even damage your portfolio, because you have to ask it very, very intelligent. And very, very holistic approach for preconceptional care. It includes a comprehensive care for delivery, as well as integration into primary care and empowering informed choices. So every news that comes for a new life, it has to be as a second picture, because we are building healthier communities. But it is not like the first picture where you are astonished when this double line comes into a pregnancy test kit. So pregnancy counseling gives opportunities for disease prevention and health promotion. It improves family planning and pregnancy outcomes, and it enhances reproductive health and preparation for parenthood. So we all, at every birth, we need to understand that two people are born, a baby and a mother, and we want both of them to be healthy, and PCG just does that. Thank you, and have a pleasant evening.
Thank you, Prerana Garu. Very nice and comprehensive presentation. And just one word to say is that we have to take every opportunity to give a preconceptional counseling, even though the patient doesn't come for that.
Yes.
So during infertility or a PCOD or any other issue, gynecological issue, she comes to the OPD, we have to take that opportunity to utilize it for preconceptional counseling, provided, of course, in India, she is married. Yeah, that is
very true, ma'am. Very true.
And obesity, hypothyroidism, and diabetes, and pre-pregnancy BMI. These are the very important drawbacks.
Very true, ma'am.
What we see is mostly getting 70 kg, they think it is normal.
It is normal, yes, ma'am.
Yeah, 70 is normal now.
It is normal.
For young ladies also.
All that maida stuff and fried stuff that they...
Yeah. It is very
Any other
nice.
chairperson? I'll be pleased to take them.
Do you routinely give this vaccination, flu vac, and of course
we give MMR and Hep B, and in flu vac we give it 24-26 weeks. 24 to 26 weeks.
Okay. Pre-pregnancy vaccination advice?
Yes, ma'am. Pre-pregnancy Hep B as well as MMR. If we check the status of IgG for MMR, rubella, and if
MMR
the IgG is negative,
in the universal immunization program, it is there, no? If any persons come from the outside India,
yes, ma'am,
and they have immigrated to India, probably their country, if they don't have that vaccination schedule, we have to check for that vaccination schedule and see if they are negative for that antibodies. We have to offer that also.
Yes, ma'am. The problem is that, ma'am, when we give an array of vaccination chart to them that you have to take this, they usually deny. So whatever is required for the healthy outcome of the baby, MMR as well as Hep B. So we usually focus on that in the preconceptional period. She can take the other vaccines even after delivery, but prior to conception, we see this. For the MMR, we check the rubella IgG status. If the rubella IgG is positive, we do not give any MMR. If the rubella IgG is negative, we give MMR and then wait for 1 month. And routinely we give Hep B if she is not vaccinated with the booster dose.
Rubella, I think it is not that common in India. Rubella.
Ma'am. Okay, ma'am.
Nice talk, Prerna.
Nice presentation. Nice
Yeah.
presentation. Which
Shama,
is
you can proceed.
the need of the hour.
Yes. Yes.
Thank you, ma'am.
Yes.
Thank
Thank
you,
you, all the
chairpersons.
chairpersons. Thank you.
Thank you. It's a nice presentation, Dr. Prerna.
Thank you, ma'am.
Hello, sir. It's a
Okay,
very
ma'am.
nice presentation. One point, sir. How can it be reached in the public? How to improve?
So this time,
creation
thank
and
you for the
awareness,
question,
because-
sir.
Yeah,
Thank
hello.
you for the thank you for the question, sir.
Yeah.
And extremely insightful question you have asked, that how to reach out to the public, because community awareness, community outreach is something which is very, very necessary for preconception counseling. As this
Yeah.
time in the AICUG, we had also a skit, sir, for the common masses, where we had almost invited 500 common people of various sectors, maybe nursing or maybe teachers or police women, and they had come and attended our skit. We did a skit on preconception counseling where we played, one person played a doctor, one person played a mom to be, another person played an auntie, the other person played a father, and we did a skit and explained how much important it is, because the skit was about yes. So such things we have to come up with a lot of such more such ideas, so we can reach out to the public, sir.
Yeah.
Okay.
Thank you, sir.
Thank you, sir.
Somlata ma'am, you want to say something?
Yeah, actually, a very nice talk. And but rather, just to tell, like than previously, at present, many people are coming for preconception counseling. Means there is a change. Like in the last 5 years or 4 years, they're coming regarding advices. Thank you.
Yes, ma'am. Shama, you can.
Yes, so let's proceed to scientific program session 3. It is on overview of female sexual dysfunction. Our speaker is Dr. Lalita, and to chair this session we have Dr. Nirmala Devi ma'am Pachoti, Dr. R. Arvind sir, and Dr. S. Sujayasri ma'am. So Dr. Nirmala Devi Ma'am Bachoti, she is the present President EOGS, Ellore Obscine Society, organizing chairperson of APCOG 2024, President APOG 2025. She has many awards to her credit, and she is a major donor to Rotary International, donated US dollars 10,000 to Rotary International. We welcome you, ma'am. Dr. R. Arvind sir, he is MD Obscine. He is a professor, Department of Obscine, GEMS Medical College, Srikakulam, AP. And Dr. Sujayasri ma'am, Sangeeta, she is MS Obscine. She is a consultant laparoscopic surgeon and fertility specialist, Seshadri Hospital, Palakol, Andhra Pradesh. She is the founder secretary of Bhimavaram Obstetric and Gynecological Society, established Palakol's first IVF center and specialized in performing total laparoscopic hysterectomy. She has a key awards, Shan S. Ratnam Eng Gynecologist Award, AOFOG 2022 Bali, and Foxy Dhira Award 2022. We welcome you all, ma'am.
Thank
Please,
you.
I request chairpersons to introduce our speaker, Lalita ma'am.
Good evening and welcome to the organizers of today's webinar on very important topics of contemporary importance, like preconceptional counseling, as well as about the two important aspects of female sexual dysfunction, history taking, as well as its overview. And let me introduce Dr. Lalita Kambhampati. As per the information provided, she is consultant and director of Lalita IVF at Helios Hospital, Rajahmundry, and the present secretary of Rajahmundry Obstetric and Gynec Society. And she completed her MS in Seth GS Medical College and KM Hospital, Mumbai. She was the senior registrar at Bark Hospital, Mumbai, and she had her fellowship in reproductive medicine and infertility from Hegde Hospital, and also fellowship in hysteroscopy and laparoscopy from North Karni Medical Foundation, Gujarat. and and we must all appreciate her special interest in having towards sexual medicine and menopausal health, which are much neglected by our own professional people. And to her credit, she has presented quite a good number of papers in national conferences and published in the national and international journals. A, a big applaud as well as a warm welcome to Dr. Lalita to present her much informative overview on female sexual dysfunction. It is, in fact, a neglected area, although some 40% of the female population are affected to a certain degree of female sexual dysfunction. That's what estimates say, and including in our parts, various studies. And what is more alarming is that it is a growing menace. It's of escalating proportions. What our parents, grandparents in their at 1930s, 40s were enjoying with regards to the sexual health is not is rather deprived to the millennials generation, and much more deprived to the present Gen X. So we need to have a good insight. We basically the Afghan people who are the first contact care for any female patient, not only for their obstetrical and gynecological needs, but they look towards us as their primary care physicians. So it is in this regard. So taking sexual history and unless we ask some specific questions and make her comfortable to open up. Generally, women are modest and they don't come out with this vexing problem, which will affect not only their sexual life but also indirectly the quality of a woman's life. And so it is in this context that I request Dr. Alita to have a good exposition about female sexual dysfunction. Welcome, Dr. Alita Garu.
Thank you, sir. Thank you for that elaborate introduction to the topic and to myself. Hello, everyone. I'm Dr. Lalita. So I will be presenting today about overview of female sexual dysfunction. So the first thing we need to discuss about is why do we need to know about sexual dysfunction, female sexual dysfunction. So as you can see, we have many patients coming into our OPD, and a lot of time we might be busy, we may not be comfortable talking to them about sexual dysfunction, but sexual health is as important as medical and physical health. And what is very important is, like sir said, due to our innate inhibitory feelings towards sexual concerns, or due to our socio-cultural environment that we as women grow up in, women might not be able to just come out and tell their problems. So we as gynecologists, we are uniquely placed at a position to help them achieve their best sexual health. And female dysfunction, female sexual dysfunction is one of the most underappreciated and underreported aspect of women's health. So I will now present a series of studies where in a study done on prevalence of sexual issues in a gynecological clinic. So in our OPD, just like my random questionnaires, they saw that 42% of women reported sexual issues, and more than 98% of them felt comfortable discussing it with their gynecologist. In a UK-based study, 42% women reported to a GP that they had at least one sexual concern. But when it is a general practitioner, only 2% were reported with the clinician. In a large sample of urologists and gynecologists, 51% of the doctors considered screening for sexual dysfunction very important, but only 22% screened their patients. This is a very important point to be noted, that yes, some of us feel that it is important to take sexual dysfunction into account while we are talking to our patients, but how many of us actually bring it up? So today we will discuss what all we can do. Then in another large study, by a sample size of 27,000 patients with sexual dysfunction, 77% of them did not come and ask for professional help. 9% reported that the clinician had initiated the conversation, and over 40% feel clinicians should inquire about the sexual health. So lack of training and maybe lack of comfort or inability to bring it up in a normal conversation and lack of time are major barriers for clinicians taking sexual history. This is another study which was done in India, and they were screening women with depression but without any medication. So treatment naive patients of depression in a general hospital in South India especially, and you can see that more than 50% of women, especially ones with some sort of mood disorders, had indicated that they had major issues of sexual dysfunction. So now we will try to understand what are the phases of sexual cycle and how can we start diagnosing sexual disorders in our patients. First, what we need to understand is that when it comes to sexology in a clinical point of view, Williams, Masters, and Johnson had done groundbreaking study about sexology and sexual issues. What they had come up with is that they have proposed a model of sexual response cycle. In that, they spoke about arousal, orgasm, and resolution. It was later modified by Kaplan by adding desire. So desire is a motivation to have sex or mental arousal. Sexual tension starts to build in this phase. And then there are some physical changes which I will be talking about later. Then there is a phase of arousal where the physical changes are intensified, they're more equally obvious, and sexual tension builds. This plateaus, and after the sexual tension builds, there is a sudden, forceful release of sexual tension, accompanied by involuntary muscle contractions, which is called the orgasm. And finally, all of these physical changes go back to the baseline state, and which is called resolution. So, initial desire, there is a hormonal effect. Dopamine is excitatory to the neurocenters, and serotonin is inhibitory to the centers. So once desire starts, there is excitement, and here we have a phase of arousal as evidenced by enlarged clitoris, perivaginal arterial dilatation, expansion of inner vagina, nipple tightening, and an erection of the nipple, and even the clitoris coming out from the glands. In the plateau phase, which is the continuation of this arousal phase, is a lengthening of inner vagina length and width. Then during orgasm, there is elevated spleen contraction and other physical changes, which is followed by resolution. But this linear model did not seem to explain a lot of sexual issues that women face. Most important of which is that this is not a linear model. It is more of a circular model where there are factors like positive factors and negative factors which vie for control in the sexual cycle. The linear model was easier to explain a sexual response cycle of men, but not in women. So this curvilinear model or a circular model was proposed by Dr. Basson in a study published in 2001. So a woman first has some positive factors like desire for intimacy, a stress relief or orgasm. She should have a comfortable environment. Then there should be motivation and receptivity for sexual advances. Now this usually starts outside of the bedroom for a lot of women. There are a lot of biological, psychosocial, and cultural factors which are involved in desire and then which can lead to excitement and arousability. There are a lot of women for whom past memories also inhibit the sexual response cycle. It can be anywhere from a past painful sex, a negative experience, negative sexual experience, or for a lot of them, they are brought up with negative attitude towards sex or the permissibility of for them to give permission for themselves to enjoy sexual advances. So all of these factors, along with other factors like uncomfortable environment, sleep deprived, non-receptive partners, negative past memories, all of this also can improve or they can inhibit a woman from having a healthy sexual cycle. So we have now in the late after 2012, 2015, many studies which have shown that biological, psychological, socio-cultural, and interpersonal effects are there, which will really affect a sexual response of a woman. Biologically, it can be physical health, neurological health, endocrine function. It can be any surgeries or radiation, any physical factors. Psychologically, it can be a performance anxiety, impaired self-image, depression, and socio-culturally, like I had mentioned, it can be upbringing, where sex is seen as something negative or dirty. There are many cultural norms and expectations, many of which do not really encourage a woman to come right out and talk about sexual health or to talk about sexual satisfaction. There are perceptions there are many negative perceptions which a woman can undergo when talking about sexual function. And most important, when we are talking about sexual health, is the interpersonal relationship. So the quality of current and past relationships, intervals of abstinence, and life stressors, their mood and other factors, any relationship conflict, environmental concerns in the house, all of them also have a negative effect on sexual health. So neurologically, in the hypothalamus and limbic systems, we have some factors like testosterone, aphrodisiac drugs, and other stimulations, which will improve sexual desire. Psychologically, it can be an attractive partner, erotic stimulation, fantasy, love, and courtship, which is very important for women. Equally important are the sexual suppressors like hormone disorders, drugs with sexual side effects, depression, and partner effects, stress, anger, negative emotions, which will lead to sexual avoidance. So, with these four phases of sexual cycle, the main criteria for classification of sexual disorders were proposed by the Diagnostic and Statistical Manual of Mental Disorders, which is DSM. Initially, it was DSM-4, but then in 2011 to 2013, DSM-5 was introduced, where the definitions were changed and some of the sexual disorders were removed or renamed. Similarly, international classification disorders by the WHO, ICD-10 and ICD-11 also tried to define these sexual disorders. Mostly today, we will be talking about classification by DSM-5. So here, they spoke mainly about sexual dysfunction affecting the sexual interest and arousal. Initially, there was a desire disorder, arousal disorder. So all of that was removed. Lack of sexual desire, lack of sexual arousal, all of that was combined into female sexual interest and arousal disorder. And failure of genital response or lack of sexual enjoyment was considered into female sexual interest or arousal disorder. Then female orgasmic dysfunction has not been changed. Sexual aversion was removed. Vaginismus, vulvodynia, dyspareunia, all of them were clubbed into genitopelvic pain or penetration disorder. So today we will be mainly speaking about female sexual interest or arousal disorder, female orgasmic dysfunction, and genitopelvic pain and penetration disorder. So the etiology, like I said, can be multifactorial. So for desire, arousal, orgasm, and sexual pain, importantly, psychological factors will be there. There can be emotional or physical distress. And in desire, it can lack of desire can be pointed out for hormonal disturbances like menopause and many medications like antidepressants, anxiolytics, and any physical problems like post-surgery, post-radiation, or chemotherapy. Arousal disorders also similarly can have etiology of psychological factors, trauma, surgery, and medications. Orgasm, again, we can have some aspect of emotional or sexual abuse, which can lead to anorgasmia, and decreased hormone levels, trauma, surgery, medications, again same. In sexual pain, what is important is to rule out endometriosis and pelvic infections, and again psychological factors, any previous negative sexual experience or some any inciting factors or triggering factors causing extreme amount of pain or aversion to sexual disorders. The medication causing female sexual dysfunctions can be broadly amphetamines, antacids, antidepressants. Most important is selective serotonin receptor antagonists, and antihypertensives, antipsychotics, anxiolytics, oral contraceptives also to a certain extent, phenytoin, bromocriptine, etc. So now, as gynecologists, it is most important for us to first bring up the sexual history to help diagnose these female sexual disorders. Most commonly, we can have some questionnaires like this where we can include this into postgraduate training, like we have done with reconstruction care, like Dr. Prerna was talking about. So such structured interviews and models which will help us to talk to a patient are very important in diagnosing sexual disorders. So a questionnaire like this, where we have the patient identification, partner identification, and to talk about the quality of the relationship, main sexual complaint, history of the current sexual complaint, previous treatments or use of medication, gynecological and obstetric history, sexual history, current emotional status, current conditions of sexual response, as pertinent to desire, arousal, orgasm, sexual impulse, sexual fantasies, masturbation practices, satisfaction with sexual life, male partner sexual function assessment. This is the most important because more than 50% of women who come with sexual problems also complain about undiagnosed sexual issues like erectile dysfunction or premature ejaculation in their partners. It is also important to talk about their affective relationship, whether they're affectionate, and finally, some lab tests like thyroid, prolactin, and hormonal tests, if they are pertinent, they are very important to be addressed. This is a model which is a very simple model where we can use this model to first train ourselves to first how to bring it up and how to talk about sexual health to the women. So this is called the implicit model. And the first part of it is to give permission, to give patient permission to speak about her sexual health. And once they talk about it, it is important to affirm and acknowledge, saying thank you for sharing, and to highlight the importance of sexual concerns. Then give limited information, like give accurate sex education, female sexual response cycle, impact of aging on sexual function, to discuss anatomy. Incidentally, just today, I had a patient who wanted to talk about contraception, was feeling shy about it, and usually we, in our OPDs, normally we say, use barrier contraception, use condoms. Today, I had a grown woman and man coming and asking me about how to use a condom. So it is very important for us not to assume that patients have or they are educated about sexual concerns, and it is important to ascertain their level of understanding of sexual health and to help them educate properly and improve awareness. Then the third step is to give specific suggestions, how to increase sexual function, like lubricant use, vibrator use, ways, and most importantly, ways to increase emotional intimacy. Then intensive therapy is when they actually have major sexual health concerns. So then we validate the patient's concern, and then we can refer her to a subspecialist. We also have some questionnaires like this DSDS screener to help answer the concerns that the patients have, and to understand and to even understand the severity. So we have other questionnaires also like FSFI, etc. Through which we can ascertain if the patient has any of the following disorders. The most important thing to diagnose sexual dysfunction is that the concern should be there for more than 6 months, and it should be accompanied by significant personal distress, like frustration, grief, guilt, feelings of incompetence, loss, sadness, worry, feeling of inadequacy as a woman. So these are important concerns, and the presence of personal distress then signifies the need for immediate evaluation and treatment. Since this is just an overview of female sexual disorder, I will be talking very briefly about each of the 3 disorders. So the first one I would like to talk about is genitopelvic pain and penetration disorder. Most of us in our OPD, especially if we are practicing with infertility concerns, can see patients come to us seeking childbirth, but on evaluating, at least 30% of them have not consummated their marriage, or they are not comfortable with intercourse, and it can be a sudden experience of pain during penetration. So what is important to ask about is, has this been lifelong? Has she experienced this with other partners if she has had any, or is it a sudden thing? Even if she had only one partner, was she comfortable having penetrative intercourse prior to presentation, or is it something which has been acquired recently? And it is characterized by the presence of more than one of the following symptoms. And like I said before, it is important before we diagnose a patient of genitopelvic pain and penetration disorder that these issues be present for equal to or more than 6 months, and there is significant personal distress due to this condition for the patient. Deep pelvic pain or tension during penetration, or superficial burning vulvovaginal pain caused even by a slight touch. Fear or anxiety before, during, or after penetration, which often leads to decreased sexual desire or avoidance of sexual activity. Reflexive tightening of the vaginal muscles when vaginal entry is attempted, making penetration difficult or impossible. Female sexual interest or arousal disorder is an absence of or decrease in more than 3 of the following for more than 6 months. That is, absence or decrease of interest in sexual activity, initiation of sexual activity, responsiveness to a partner's initiation, decrease or absence of excitement or pleasure during almost all sexual activity, absence of sexual or erotic fantasies or thoughts, genital or absence of genital, non-genital sensations during sexual activity, and absence or decrease in interest, arousal in response to internal or external, sexual or erotic, written, verbal, visual stimuli. Female orgasmic disorder is defined as orgasm which is absent, markedly diminished in intensity, or markedly delayed in response to stimulation, despite high levels of subjective arousal. These symptoms must occur during almost all sexual activities and must have been present for at least more than 6 months. And like the previous disorders, we need to see if this is acquired or if that it has been lifelong. Almost all women with sexual dysfunction have features of more than one disorder. For example, a genitopelvic pain and penetration disorder often leads to lack of sexual interest or arousal when there is pain. And the impaired arousal may make sex less enjoyable or even painful, decreasing the likelihood of orgasm and subsequent sexual desire. However, pain during intercourse due to impaired lubrication may occur as an isolated symptom in women with a high level of sexual desire, interest, or subjective arousal. So that we know is easily treated by just advising a use of lubricant. Now, how do we manage? This is very much inconcise. So when we have a patient present with genitopelvic pain or penetration disorder, we need to first ascertain if there is pelvic floor muscle tension. We can see this by just like a very gentle single finger examination, but sometimes even that is not allowed by the patient. They can have fear of vaginal penetration, and if they have history, we need to ask about sexual violence, sexual repression, and all of the negative attitudes that they have towards sex. Presence of any of these, then we need to advise psychotherapy, and we need to send them for kinesiology or electrical stimulation, block of trigger points by using lidocaine or botulinum toxin therapy, and to explain muscle relaxation therapy. When there is fibrosis, or is it after radiation or surgery, then we need to advise vaginal dilators, or sometimes examination under anesthesia with serial dilatation of the vagina. If there is genital atrophy, then we will obviously have to see the origin of it, check for the hormonal status, and prescribe as necessary just a lubricant or hormonal therapy if they have other reasons of vaginal atrophy like menopause, and if they have other symptoms of menopause like hot flashes or osteoporosis, so then HRT has to be initiated. Infections have to be treated, and any scars, if they are pertinent, can be removed, or cosmetic surgery can be attempted. For female sexual desire or arousal dysfunction, first we need to rule out a physical or an organic cause, and then ascertain if they have psychiatric problems. So, physical causes, we need to see if they have any infections or if they've had any surgeries, then ascertain again for hormonal alterations by checking prolactin, thyroid, testosterone, glucose, and CBP and other specific tests. If there are genital infections, we have to treat them properly. We have to educate physiotherapy, relaxation exercises, etc. And for hormonal alterations, like I said, hormonal therapy can be added. If they have psychiatric problems, if they have to be first encouraged to talk about their problems, and if they have sexual repression, so we need to talk about their attitudes or cultural upbringing, and then try psychotherapy, cognitive behavioral therapy, and other sex therapy that can be utilized. If they have history of sexual violence or negative sexual experiences, then they need psychological counseling, and we need to refer to a psychiatrist. We have some medications also which are used for female sexual disorders. Like I said, estrogen replacement, use of lubricants for vaginal dryness are one of the most commonly used medications as gynecologists. We need to be very cognizant about the estrogen prescription, and topical estrogen is always preferred due to so that we can prevent any occurrence of venous thrombosis or any estrogen dependent tumor growth. And this is especially useful for symptoms associated with menopause. Lubricant can be is generally well tolerated, and it can be applied internally or externally, and it is very frequently prescribed by gynecologists. Now, when we come for specific treatments for sexual arousal and so female interest and arousal disorders, testosterone gel has been used, but mostly this has been an off-label use. We have many side effects which can occur, but testosterone gel, like as infertility specialists also, we can attest to that, to its efficacy. So testosterone gel has been utilized in women with decreased sexual arousal or desire. Sildenafil, which is a phosphodiesterase inhibitor, has been, we all know, it has been prescribed for men, but there is an off-label use for women. Studies have shown that it is of more use for younger women, especially in women having arousal disorders. Then there are other drugs like phentolamine, which is an alpha-adrenergic receptor antagonist. It improves vasodilation, and it is generally well tolerated. It improves arousal and genital lubrication for women. Bupropion has been a very important therapy which is used for women who have been treated with SSRIs for depression, and without discontinuation of SSRIs, by just decreasing and modifying the dose with addition of bupropion, we can address the sexual issues occurring with the SSRI intake. For sexual arousal disorder, topical cream of alprostadil, which was used for male sexual problems like erectile dysfunction, has been tried, and again, it is not FDA approved, but it is an off-label use. So we have some other medication which have not been used, or it has not been scientifically proven as yet. So management of female anorgasmia. First, we need to rule out any medical condition like natural surgical menopause, endocrine disorders, neuropathies. Very importantly, why we test for diabetes is to rule out autonomic peripheral neuropathy. And for menopause, we can administer hormone therapy like estrogen, estrogen progesterone, or even testosterone, timolol, all of these drugs. And for endocrine disorders, we need to first advocate sugar control and neuropathy. We need to send them for physiotherapy. Now, people with anorgasmia sometimes come with the complaints that they are not aware of the genital anatomy, they're not aware of the function of the clitoris, and they can have so here, partner education also is very important about erogenous zones, oral sex, masturbation, and even about foreplay. And so we need to educate partner also here with the patient individually and together, so that they can understand the issues, and we also can see specific if there is a specific cause for the anorgasmia. For psychological condition, for interpersonal relationships, so they need couples therapy, psychotherapy, and other cognitive behavioral therapy. So again, this is similar flowchart, but this actually tells us very quickly if there is a primary or secondary, if it is a psychosocial cause or a sexual hormone deficiency or other factors, and we can then treat it accordingly. What is very important is to first address their sexual concerns, to validate the sexual concerns, to diagnose them properly, and then we can send them for specific interventions. Thank you.
Thank you, Dr. Lalita, for that wonderful presentation. That's a topic which is not commonly dealt, so I'm sure it will benefit everyone who's watched
Actually, it
it.
is a very extensive topic, and I had to try and tell it within just 20-25 minutes. So I couldn't go into specifics, but each of the topics actually have to be dealt with separately also. It is important for us as gynecologists to be aware of what all can go wrong, and to first identify in the patients and to help them.
We have to make an attempt to talk to them and give them the time. So it was a very good presentation. Thank you once again.
A lot of kudos to Lalita for wonderful, elucidating a sensitive topic. I have a few questions for you. Can I ask
yes,
you?
Sir.
Yeah, one.
Sure, sir.
One thing, being gynecologists, I think we should be more concerned about the role of hormones. And here in women, there is what is known as a infradian rhythm based on the menstrual cycle, where the level of the hormones, in particular estrogen and progesterone, will be fluctuating from the follicular phase to luteal, ovulatory phase, luteal phase, and menstrual phase. What is the what is the role of this infradian rhythm with regards to sexual health and dysfunction? That's my first question. And the second one is, there is also an important area of musculogenic dysfunction, particularly in people with voiding dysfunction. In all, we should ask about their adequacy of sexual satisfaction, because if there is either hypertonicity or hypotonicity in the pelvic musculature, that affects the quality of their sexual life. So that's again one area. And I have the third question from my side is, what is the role? There are a lot of knowledge and information load about various pharmaceutical agents. In particular, what is the role of intranasal apomorphine, topical sildenafil, topical alprostadol, and also one FDA approved drug? Do you have any experience with flibanserin and brepronide? I think
Flibanserin is not equally available in India, sir, first of all.
Okay.
Second, alprostadil was used it's been being used for men, and in women we don't have enough studies to talk about it. But yes, off-label use of alprostadil has been occurring. See, topical testosterone, yes. So that many infertility specialists can attest to the fact that it has improved, not just, so we give it for improving ovarian quality, oocyte quality, but also like there have been not like extensive studies and not randomized control trials, but yes, with like use of topical testosterone, there has been improved libido and improved physical signs of arousal, and so other factors which have shown that they can be used, but all of them are off label. And the first question you asked about see,
Infrared rhythm based on menstrual cycle, and what is the impact of it on the sexual health and dysfunction?
so see, we all know that when hormones are low, especially sir, hypoestrogenic states, right before menses, during pregnancy, and menopausal states, all of them have
So
low libido.
what do you advise during those phases when the hormones, the so-called accelerators for sexual development and
Yeah, so like sir, if you see that so in my presentation also, there are equal number of sexual inhibitors and equal number of sexual stimuli. So they need to apply more of the sexual positive sexual factors, like interpersonal factors also very important, how the woman feels about herself. So maybe in those at those times where women are not feeling that they have enough libido, other methods to improve the sexual stimuli, it can be verbal, can be non-verbal, it can be physical touch, it can be a good interpersonal relationship. So this we can stress. So the whole point of
but so there is a place for lubricants during these times, in particular during the follicular phase as well as the late secretary phase.
lubricants can be prescribed at any time, and we can leave it up to the discretion of the patients to use it as and when necessary. But what I was trying to point out is that it is very important for us as gynecologists to we can just point out, so to the couple, not just the woman, to the couple, that there are factors which will improve their sexual health.
Yeah,
like
is a big
by counseling and educating the husband, talking to them about foreplay, talking to them about non-verbal sexual stimuli, verbal and non-verbal sexual stimuli, even before starting foreplay. All of these will help the woman achieve a good sexual health, is what I think.
Yeah, they are big accelerators. And one last question is
speech, Dr. Lalita.
Last question.
Ma'am?
Excellent speech.
Lalita, can you elaborate on the role of nutraceuticals like the so-called Korean ginseng, L-arginine, ashwagandha, shatavari, and there are about this
So nutraceuticals are being used. There have been some studies, especially on Chinese ginseng and ashwagandha, which have improved libido in both men and women. L-arginine, as we all know, will improve vasodilatation as a nitric oxide donor, and but they are not a treatment unto itself. It is just an additional thing that we can give to improve the sexual experiences. But what is more important is that it has to be a multifactorial treatment. We can't just say take these medicines and you will be fine. This is not like we are treating an infection by giving antibiotics. So we need to be aware that there is a lot of counseling which goes into treating a patient for sexual concerns, and it is mostly, I believe, 70% counseling and just 30% whether it is nutraceuticals or drugs.
Wonderful. You had thrown a lot of light about a rather perplexing and intriguing problem of FSD. Congratulations to you. Thank you.
Lalita, excellent speech. I must congratulate you. I know you have a lot of passion towards this medicine, sexual medicine. Really did a really great job. And I have a question. I know female sexual dysfunction is a complex interplay of emotional, socio-cultural, relational, and physical. But still, unless we treat it empathically and sympathetically, that may lead to not only marital disharmony, depression, anxiety, and sometimes in extreme cases, divorces also. So, really like your talk, but I have a question that do the lasers which are projected in this modern era, do they have any role really? Do they get any relief with these lasers for vulvodynia or penetrative problems and all? Do you believe that?
Yeah, I think, ma'am, you're talking about G shot and O shot,
Yes,
PRPs,
yes, yes, yes.
hyaluronidase. Again, ma'am, we don't have enough studies for it. There are people who believe wholeheartedly in them, and I think there are some studies which say that basically these are either hyaluronidase shots or sometimes even PRP into the G spot. But G spot is not a physical area. It is said that it is just on the posterior vaginal wall. It is a bundle of nerves, and that is the area which is more sensitive. So how much there are? I have tried to find enough studies, but really we couldn't find any good, RCT or something like that, which will tell us that yes, these are completely effective. But as far as the hyaluronidase shots go, if done safely, they should not have much side effects, and we can try giving them. And like you said, it is a lot of interplay of lot of factors. So we need to simultaneously address all of them. And I completely agree with you, ma'am, about divorces. And as infertility specialists, especially, we talk to patients, and most of the time they have sexual intimacy only for procreation, which again increases the sexual problems. There is a fear of performance anxiety from the men's side, and some clinical attitude towards it from the women's side also. So we need to address all such small factors which we may not think they are very important, but all of them are important. And I think recently these shots have been used, and many cosmetic procedures are coming up, but strictly speaking, we still don't know if they are as effective as they are being promoted.
What about vacuum clitoral therapy device?
I'm not aware of its use. I mean, I think it's more outdated right now. There are some vacuum devices for erectile dysfunction in men, but at that time they have launched such vacuum clitoral devices, but they are not in use. And I have not come across many of them in the present era, sir.
Okay, okay. Very nice, Lalita Garu. You have done an excellent job.
Thank you.
Okay, thank you, ma'am, for the excellent. Any other comments? Sir, Madan sir, if it is done, please you can say vote of thanks. Madan sir?
Madan sir, it seems.
Yes, I am there. It was a wonderful talk and wonderful discussion with great questions and
Thank you,
answers.
sir. Thank you for giving me this opportunity. First of all, sir, thank you so much. And thank you for bringing up sexual health and, taking it to all of the country and all the societies. So that is a great job you're doing, sir. Thank you so much.
Yeah, you have done a great job. Very nicely compiled and overviewed the topic. Thank you, all the chairpersons, on behalf of AMOGS. I would like to extend my sincere thanks to my guest Madhuri ma'am, Kiran sir, Padma Sajja ma'am, and Venkat sir. Of course, our dear friend Dr. Shama, who has coordinated so well, and Prerna, Dr. Lalita, and all the presidents and secretaries of Associated Societies of Andhra Pradesh who presented to me and with joy. And really, we enjoyed today's academic session, especially the last session too much. Thank you so much once again, all the AP societies on behalf of AMOGS. And thank you, Corona Remedies, for the academic support. Thank you so much once
Thank you,
again.
sir.
Yeah, we'll meet very soon in future too. Yes, thank you so much.
Thank you, sir. All the best to your future elections upcoming.
Yes,
Thank you.
ma'am, send your brochure again, whenever
Yeah,
it is
sure,
ready.
sir. Sure,
Yeah,
sir.
copy.
We'll do
Yeah,
it.
and we couldn't meet at ASU. I think you left early, na?
Yeah, we left a little early.
Yeah, I saw Somlata ma'am, but couldn't meet.
So soon
I
we are going. We'll
Tripur
get
Sundari
that
ma'am. I met,
opportunity, sir.
yeah, I met Tripur ma'am.
So welcome to our Yuva Foxy. Once more, I'm requesting everybody and make it very, very successful. Thank you.
Yes, thank you once again. Bye. Good night.
Bye. Good night.
Thank you, everyone. Thank you.
Thank you.